Good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me for Facebook Live today. So today's broadcast, two parts. First part, a little COVID update as usual. And second part, and the majority of what we're going to have today is Dr. Rob Whittaker, who is the oral surgeon here at CGH. And I have some questions for him, and you're welcome to send some questions to him as well. So that's the plan. Let's get at it. So let's talk COVID. Matt's going to show us our local numbers just to kind of see where we're at lately. Yeah, so the red is the most recent. Blue is, so that red is this week. Blue is last week before that, excuse me. And then the one below one of the bar graph, the red is the most recent 2 weeks, and the blue graph is 2 weeks prior to that. So you can see a little bit more of a trend up, definitely not like November, but it's definitely a trend up. And as we talked about last week, it tends to be more in the younger crowd. And what we're seeing across the country is mainly unvaccinated folks. So that's kind of where, and on the right there, you see our positivity rate and cases and that type of stuff. So thanks, Matt. Appreciate that. And, basically the biggest player right now, the thing folks are obviously talking about is this Delta variant and any other new variants that might pop up, because those are still the wild cards in this whole situation of the pandemic and how long it's going to keep playing out. And basically, at least right now, those places that have lower vaccination rates tend to have higher numbers of COVID cases. So I did want to, something else popped up this week, and I was talking to one of our employees, and she was saying, I have friends that talk to me about all the bad things they see of people who've had immunizations and been vaccinated for COVID on, let's say, Facebook or something like that. And how do I respond to them? And, I said, that's a valid question. And how I would respond to that is that, vaccines have a risk to them. They always have. And so, you're going to have some folks who have any vaccination that have a reaction to them. However, if you look at an entire population, whether that be Whiteside County, the state, the bigger the population gets, the more that you see that the benefits of having a COVID vaccination and the illness and deaths that it prevents begins to outweigh more and more and more any individual negatives that occur as a result of getting vaccinated. So that's how I look at it. And also, people don't post that, by and large, hey, I'm doing great, because that doesn't draw people. What draws people is the negative. So that's something that I want you to keep in mind. And there's a risk of vaccines, but that risk is way, way, way less than the risk of getting COVID and then having complications long-term from that, and potentially dying from COVID. So, and in terms of our vaccination rate in our county, I just checked on this today. We are at 42.034% are fully vaccinated. I don't know what percentage have had partial vaccination status. And in the state of Illinois, fully vaccinated, we're at 57.5%. So we are lagging the rest of the state in terms of our vaccination, fully vaccinated population. Now, granted, you take in that, so a fully vaccinated 42%, that's about 23,000 people in Whiteside County have been vaccinated fully. And we know at least 7,300 people have had COVID. And maybe some of those people who have had COVID have also had the vaccine. So the variables there are how many people have really had COVID in our county. We know it's more than 7,300. And, to what extent does partial vaccination help some folks? And whatever you end up with for that number, when you add up fully vaccinated, partially vaccinated, have had COVID, that is the number of potential folks who help to create herd immunity. And then you divide that by the total county population. Yeah, I don't have exactly what that number would be. I would just say that our county has a little more risk of having some more cases here going forward for some period of time if our vaccination rate still lags. So it's just another reminder that, man, if you can get vaccinated or know someone who's kind of on the fence, if you could share some of this with them, encourage them to talk to their own physician. Yeah, just the more the merrier that we can get vaccinated, the more opportunities we have to keep things kind of where they're at right now in terms of COVID in our area. All right, that's what I wanted to share about COVID today. Hope that was helpful. Any questions during the rest of the podcast, the rest of the Facebook Live, feel free to send them my way. But what I want to do now, I want to bring in Dr. Whitaker. Where's Dr. Whitaker? There he is. Hey, Rob.
Good. Very good. Hi, everybody.
Yeah, I was Dr. Whitaker's on top of things. Dr. Whitaker, we were just laughing before this started. He's the only guest that sent me a reminder the night before.
Mama taught me right. Yeah. Never be late. Yeah. Hopefully, thanks for the invite. I hope this won't be your jump the shark episode. You ever hear that?
No, what's that all about?
That means, when a show, the quality of the show goes down. That's like this episode, like where the Fonz jumped the shark on the Happy Day show. So I hope I'm not known as that episode. But
all right, I don't remember Fonz jumping the shark. I definitely remember Fonz and the demo derby with Pinky Tuscadero.
Yeah. So, we're old.
Yeah, you know it. So, okay. So let me get into it here with you, Rob. You've been here for, 20 years?
Yeah, I think February 99.
Okay.
Yeah.
20 plus.
Yeah, it's going quick. That's hard to believe.
Yeah, I know.
So,
you were just a young buck when you showed up.
Yeah. I think I had a little bit of hair still, maybe not.
All right. So I wanted to start before we're getting into the oral surgery type of questions, just a couple things about your training. So you're a dentist and a physician, correct?
Correct. Yes.
Yeah. So how does that work? I mean, did you do dental training first, then medical training, and then did you have to do fellowships after that?
No. Okay, kids, whoever wants to be an oral surgeon, this is the way it works. I encourage you to check it out. But traditionally college, then you get into dental school, and 4 years of dental school. While you're in dental school, people choose, I want to be a general dentist, or they may want to be an oral surgeon, orthodontist. So the next thing is you apply for specialty training, and you have to be accepted. So some of them are pretty competitive. So if any of you kids want to be oral surgeon, make sure you study hard in dental school, get your grades. But then you get accepted into a oral maxillofacial surgery residency program. Traditionally, they're 4 years. So you go finish dental school, you go to this residency program wherever it is. Generally, it's a hospital-based kind of program. Then, you put 4 years in for that. When I was applying back in the 90s, early 90s, there was this talk, they were just starting to have these programs where they wanted to put oral surgeons through medical school. And I was a little worried that I would not get in one, if I wasn't in one of those programs when I finished it. Is that going to be the requirement to have an MD? So I applied, I wanted to try to get into one of those programs. There wasn't very many. In Illinois, back then, there was 2 guys, one from Northwestern, one from U of I, that they put through the medical program. Everybody else just went through the traditional. So they were testing it out, basically. Thank goodness I got in one, and that's what brought me to Illinois, quite honestly. I'm from Pennsylvania. So then they put you through medical school. You do get credit for 1 year. So you go in, and the first year basically had credit for. You had to apply, do all the things to get in. But then you do 3 years of medical school. As far as more trainings, then I did a year of general surgery training. Then I came back and then finished up my oral maxillofacial surgery training. But it's all packaged together. You have to get into the medical school, and it's part of the program. It's kind of never really ended up. It became popular for a little while, but right now, like in Illinois, I don't think any of the programs, they never really continued it. So I think most of them now are 4 years of residency afterwards.
Okay.
And you can go on and get fellowships, like you mentioned, and there's guys that get head and neck surgery, oncology fellowships. There's facial plastics, cosmetic fellowships you can go on to after that. Usually you have to go through one of the MD programs to do that.
Okay.
So
You're already starting to get shout outs, Rob. I see Donna just shout. There we go. And there. Oh, here we go. They're going to keep coming. I know it. I was talking to someone else I was talking to one of our nurses in the hospital this morning, and I was saying, hey, she goes, who are you interviewing today? And I go, Dr. Whitaker. And she goes, I love Dr. Whitaker. When I had my moderate sedation, I told him I loved him afterwards.
Well, I love the patients. I mean, that's the best part of this is meeting. I meet a lot of nice folks, and we have a good time. And I mean, some of this stuff, the latest stuff. I got these. I know we're getting off course, but I mean, like these guys make these nice little plaques for me, and they bring little.
Cool.
I got a whole collection of chattering teeth. I got some guys bringing jelly in.
Nice.
So we have fun with patients, but let's get back to it.
Well, no, I think Dr. Whitaker is basically, if you go to see him, you better be bringing something like that to him.
No,
forward. All right, so let's get into some of these questions here, okay?
All
right. What exactly are wisdom teeth?
Oh yeah,
wisdom teeth.
Wisdom teeth. Yeah, every kid's they hate hearing of that. They go to the dentist. They're a teenager, and the dentist tells them, "Hey, listen, it's time for your wisdom teeth to come out." Wisdom teeth, third molars, teeth 116, 17, and 32. That's what we call them. They're the furthest back molar in our mouth. Some people don't have them. They're likely to they have congenitally missing ones. Other people have extras, which is not fun. But we don't know why. I mean, over the years, what's the purpose of these wisdom teeth? A lot of people don't have any room for them. So the number one way people meet oral surgeons is wisdom teeth. I mean, a lot of times that's the first procedure kids have as a teenager.
Yeah.
But usually we try to snoop around as a dentist when you're about, it's roughly 16, the common age for jaws to be done developing. And you can kind of snoop around and see, is there going to be room for these wisdom teeth to come in?
Okay.
And, if there's not enough room for them, it's wise to remove them when you're younger.
Okay.
And so you kind of want to look around and see what's going on. If there is adequate room for them to come in, I mean, you can let them erupt, and hey, I mean, I've taken out, I don't know how many, hundreds of, thousands of wisdom teeth. Mine are all in. I've got mine. I've never been through the procedure.
Okay.
So, but they're a little harder to keep clean, even if they're in perfectly. But we like to, if there's no room for them, typically they start causing some pain later on. They can damage the teeth that they may be pushing up against or directly in front of them. They can lead to what's called periodontal disease around the second molars, the teeth in front of them. When you're a teenager, they often don't cause too much discomfort other than it's kind of like teething pain. But it's later on you can start having problems. The problem with removing later is at that point, it's kind of like weeding the garden. Would you rather pluck a weed out in the spring, or if you know you're going to pull the weed out, would you rather let it grow all summer? Well, you'd rather pull the thing out earlier when it doesn't have much of a root. Same thing with wisdom teeth. Wisdom teeth get longer roots, they get curvatures of the roots. And there's also some structures that are nearby. There's a little nerve that runs through the jawbone. And this is for lower teeth in particular. To me, they're the higher risk ones and the wise to remove when you're younger. That nerve gives feeling to your teeth, your gums, your jaw, your lip, and your chin area.
Yeah.
And if the roots grow down close to that, there's a higher risk of that nerve potentially being bruised and injured with a surgery. And we get worried about that when folks are older getting it done. I mean, not only is it just a harder recovery afterwards, but that nerve being injured is, to me, the biggest issue. I'd rather see somebody early and say, well, it's not quite time, or maybe you have some room, because if it's later, it's harder to deal with, because like, okay, we're having a long conversation. Your roots are around this nerve. We're going to have to kind of get this thing off the nerve. There's a higher risk of being injured. So I do like to get patients seen earlier if you can. And I guess not so much with the uppers. It's really the lowers. And they tend to be the ones that are more often crowded. So,
okay. Okay. So like when I've heard the term dry socket, does that have anything to do with what you're talking about in terms of the
Yes. I mean, what dry socket, fancy name, alveolar osteitis. It's kind of the bane of oral surgery. They've been, for decades trying to figure out how to prevent it. No one's really figured it out. When you take out a tooth, there's a hole there afterwards, and we call it a socket. It's where the roots used to be. And normally after you take a tooth out, any tooth, a little blood clot fills that hole. Just like you hurt yourself, you get a scab.
Yeah.
You put scabs in your mouth. Well, you want that little scab to stay in there, and it aids in healing. Dry socket means there's nothing in that socket. It means that blood clot came out. And okay, what's that matter? Well, it hurts. That's the big thing. It doesn't go away. I mean, if you're out in the middle of nowhere and you develop the dry socket, and you had a tooth taken out and you had to go someplace, the dry socket does get better on its own. It doesn't really need medications, but we do put like oil of clove. If you go to Walgreens, you'll see oil of clove, eugenol. We do put medicine in there just mainly to buy time to give pain relief. So you can get a dry socket after removing any tooth. Wisdom teeth, lower wisdom teeth, the number one teeth to get it.
Okay.
Risk factor. Smoking is a big factor if you don't keep the area clean. But quite honestly, we haven't figured out a way to totally prevent it. So you do all the right things and still get it, and don't feel bad. It's an odd.
Yeah. It's one of those complications of having.
Yeah.
I want to, for the viewers, send questions to Dr. Whitaker as we're talking, but I wanted about wisdom teeth, but I want to transition to another thing that I think you do quite a bit of, and that's dental implants. So how do you help patients to kind of think through, Rob, whether to go the dental implant route versus dentures, other options for their teeth?
Well, I mean, part of it ends up being financial for some folks, of course. I try to, when I see people and we're removing a tooth, I try to go over, here's the, okay, what do I do? This tooth's missing. Do I need to replace it? What some people say. And I try to explain the rationale behind replacing teeth. And there are some teeth that maybe people won't miss as much. And then I kind of go over, here's the options for it. And dental implants are nice because they're not removable. The other options are like bridges, which require preparation of the adjacent teeth. And I mean, sometimes that's not a bad deal, but oftentimes if our teeth have never had fillings or anything in them, you kind of hate to, prep those teeth and cut them down. But some people choose that option. The younger you are, the less likely you want to do that.
Okay.
We discussed the pros and cons of that. Now, some people it's a little more complicated. They may not have the tissue available for an implant. It's like not everybody's a good candidate for implants, and also based on their medical history. I mean, what kind of medical issues they've got going on. Some people, it's like, well, okay, dental implants may not be the best option because of concerns about healing, and so we tend to decide that way, looking at their medical history. And then, if it's a possibility, I tell them, hey, listen, here's your options. You do have sufficient bone there to do it, and if you don't have enough bone for these implants, okay, here's your options to try to maybe get you there. How can we make the site adequate to place an implant?
Yeah. What's the process to if you're going to have an implant, Rob? What does the patient have to do?
So you come in for a consultation, and we do radiographic examinations. Some of them are just a plain film, right? Kind of like the X-rays you get at your general dentist's office. Sometimes we do what's called a cone beam, which is like a mini CAT scan or CT scan. and and we assess the sites. Okay, is there enough bone? Do you have enough width of bone? It's like carpentry almost.
Yeah.
Implants are little dentals or little titanium screws, and you got to have enough width of bone and height of bone. And there are some structures that kind of get in the way. There's a nerve, like we were talking about with the wisdom teeth, that runs through the lower jaw. There are sinus cavities in the upper jaw, and not everybody has this enough bone, and your sinuses are bigger, and so it's kind of like, hey, my friend got one there, but you're telling me I just can't get one at that site. There's variations in sinus, sizes and things, so they get in the way. But so we look at it. Are you a candidate for this? And then I also look at. I have some people. I mean, these billboards you see on the highways about dental implants, a little bit deceptive. It's advertisements. They want to get you in. But I mean, a lot of people kind of think if I get an implant, I don't have to do anything to it. It's indestructible. I never have to go to the dentist. So I do see some people come in that aren't, they're not in that mode of getting their teeth cleaned and checkups with a general dentist. And I try to educate them that, you get these implants. They need to be maintained. You need good oral hygiene. You need to have a formal dental cleaning on a regular basis, because they can get gum disease around them. They can't get decay, but they can get gum disease.
Okay.
Which is regular teeth. So some people say, nope, that's not for me. I'm not going to change my ways. I'm not going to the dentist. And I try to implants may not be the option for you.
Yeah.
It's a lengthier process. You may take out a tooth. Sometimes you can put an implant in immediately at the site. Oftentimes you have to graft some bone into the socket, either your own bone or you can get used donor bone. Then there's a several month period of healing. So you do have to be a little bit patient, through the process. It's gotten quicker over the years, that's for sure. I mean, to me, it's way better than it was 20 years ago.
Yeah.
Our implants were first developed in the 60s. So they've been around longer than people think. They've just evolved over the years and technology.
So I appreciate, I don't know if you saw Donna's comments, but I'm sure you appreciate those about.
I wasn't peeking. So
yeah, no, that's good.
I'm new at this. I'm trying to look at the camera.
Yeah, I hear you. So you're saying that.
Get the nice comments though.
Yeah. So you're saying that you might have, let's say it's a front tooth. Would you have like a period of time where you don't have a front tooth then because you're waiting for that bone graft to kind of take and that type of stuff? Or how do you work that out?
If you can't do an immediate implant, like immediate implant is take out the tooth. And if you've got conditions right, you can put it in right away.
Oh, okay.
Sometimes if the bone's infected, you can't really put one in the site of an infection, or, why'd you lose the tooth? Was it like, infection ate the bone away? So, not to get too graphic, but there's different conditions of that site, so sometimes, we plan that out with the general dentist, like, okay, you have some sort of interim or some replacement. So you're not going totally without something, but it may not be actual final crown on the implant,
Sure. Yeah. You see that question, Rob?
Yeah. Well, we were slowed down. I mean, that shutdown where last May or last March 17th. So etched in my brain that date when we shut down. But, we were seeing emergencies and stuff. That got us way behind, because, a couple months there of when we first were planning on closing for 2 weeks. I'm like, what, are you kidding me? I was like 2 weeks. But so I'm still trying to kind of catch up with that. And, when we went back, our methods are, it's a little slower, and we're cleaning, and we're being real careful. So, but I think most dentists they're back up to speed. It's, maybe not quite totally where you were, but we're getting there. And get your vaccinations, because we don't want this thing slowing us down again. But I don't know of any dentists that aren't really back in action there. And you look at some of the studies on office personnel, dentists getting COVID, really it's low. It's amazing. Because we're in people's faces all the time.
Yeah.
It's really low.
Yeah. Thanks for your kind comments to Dr. Whitaker as well, Susan. Appreciate that.
Yeah, I appreciate it. I'm sorry, I'm missing some of these.
Oh, that's okay. I just kind of just
talk and read at the same time.
well, I get to read while you're talking. So
Okay.
that's why that's my advantage. All right. So let me throw another question out at you, Rob. So is there anything from an oral disease standpoint that may not be commonly known to patients, but you think would be really helpful and wise for them to be aware of?
Well, yeah, I mean, there's a lot. I mean, I see people all the time in my office, and certain things come up. And I mean, not everybody. This doesn't pertain to everybody, but I run into this all the time. There's these medications that people take for osteoporosis, and there's also some of them take it for if they unfortunately have like a cancer that involves bone. Medications for osteoporosis or decreased bone density, they're called bisphosphonates, and alendronate one, Fosamax. People may recognize that name, Boniva, and recently you're seeing more people being putting on something called Prolia. And their medicines, they've got great benefits to help increase your bone density, but we kind of have to warn patients that those medications can have an effect on your jawbone the more years you're on it. So I'm trying to educate patients that if you're on these medications, you have to be really good about going to your dentist, getting checkups. If you got a tooth that's got a cavity, fix it. I mean, try to avoid removing teeth when you're on those medications, because there's this thing called osteonecrosis of the bone. And it sounds terrible. Osteo means bone. Necrosis means dead. And what happens is these medications almost have like a more of it gets incorporated in the jawbone, and it's supposed to decrease breakdown of bone, and it's almost like too much gets in the jawbone, they think, and still looking into it, but so the normal healing capacity of the bone, which for most individuals is pretpretty good in the back, the upper jaw and the lower jaw, it's decreased. So if you do trauma, like you take out a tooth, that's trauma. The natural healing capacity goes down, and the bone can like die in that area. So it's osteoporosis. So I run in this, and I have to warn people of this when I see them in my office, and they're like, "Boy, I've got to remove this tooth." And I see you've been on Fosamax for 10 years, and if you've been on those medicines for 3 or more years, you have this increased chance of this problem occurring. It's small. I mean, we're talking single-digit percentages, but it is a risk. It's a hard thing to fix is the problem. It's not a quick fix, So if you're on those medications, Fosamax, Boniva, Prolia, be really good about it, or go to your dentist before you even get on it if you can, and check it out. Do you have any teeth that need to be removed that can't be repaired? Get them out so you're not dealing with it years later. So it's something I talk to patients a lot about, and they call me like, "Hey, I've got this patient who's on this medication, and what do I handle? How do I handle this?" And
right,
and there's not much you can do once you're there, and like, "Hey, I've been on this for 10 years, and boy, I've got these 20 teeth that are bad." It's like there's no reverse because you can't really stop it, and it like immediately there's an off switch for the medication.
Yeah,
it has a long half-life, and it stays in your bone for a while. So I just encourage people that are on those medications, go to your dentist and try to avoid removing teeth, and don't stop them. Then it's the other thing. I talk to patients, and then they talk to their doctor like, "I don't want to be on this medication." And there's little black box warnings now on the medication list, which nobody really wants to read. But if there's benefits to those medicines, I think they're trying to work out like how many years should you be on it.
Right.
We're trying to figure that out. What's the good time, and when should you take?
But you're saying though that if you're up to being on it up to 3 years, you're probably still okay. It's if you go beyond 3 years.
Yeah, that's what you mean. That's what they see. I mean, it's a tough thing to study because it's not a real high chance. We're talking several percentages chances, but and it takes a while, and then they're trying to iron it out. But classically it's 3 years. They've had some tests they tried. Unfortunately, it wasn't predictive. Blood tests that kind of look at osteoclast activity, which is little cells that break down our bone. So there's cells that make bone and cells that break down bone. Well, these drugs, the bisphosphonates stop the osteoclast from breaking down bone. So that test didn't work out. It would have been nice if it did, because we could just check this test and see, okay, hey, you're okay. You're probably going to heal fine. But it's small. It's 3 years or more. I get more worried about these people that are on, I get some people with these medications for 10, 15 years. And it's like, whoa. You do see some spontaneous cases of it where they just, hey, man, I got this area in my mouth, I can see bone, where the tissue found, and they've been on those medications. But often that's more the cancer people that are taking really heavy doses of Zometa and Xgeva, some of these other medications.
Yeah, good information to know. Do you ever send those folks to the wound center for the hyperbaric oxygen?
That's the problem. A lot of the studies on that don't really even show, they've looked at that and it's not really clear. It's sort of like, that's even losing favor for osteoaradial necrosis, which is a side effect of radiation treatment. It's kind of the same sort of process, but they're wondering how beneficial it is. But we still do it for that. But I haven't seen anything really firm that. There's some medications that sort of help to help increase like red blood cell flexibility and stuff. That they, sometimes they put people on that.
Okay. Sure.
And I think it's more like prevention. If you can avoid, do your best to avoid having to have a tooth removed if you can. But
that's right.
Not so much.
Sure. I want to ask you too. So, do you deal with folks who have TMJ, sleep apnea, congenital jaw defects, that type of stuff in your practice?
TMJ, I see people for TMJ. TMJ is a tough one because there's, if you Google that, there's a million ways to treat it, and it's really over the years. Back when I was in my training, I was in residency, from 1990 to 97. You could see like TMJ cases dwindling, and we were getting more conservative. We were pretty aggressive in the 80s of doing open joint surgery and things like that. And they come to find out that, there's a big group of people that have like TMJ, and TMJ is just a shorthand for your temporomandibular joint. So it's kind of like saying I have knees, but there's temporomandibular joint disorders. So I see people with jaw pain. Majority of them, it's really from clenching. I've seen a lot of it over the last year because everybody's kind of wigged out because of this COVID thing, and understandably, and I clench myself at times. That's my barometer of stress. But a lot of times that creates this myositis or inflammation of muscles, and then it leads to like a clicking in the joint and things like that. But most people are very conservative. We try not like reversible treatment. Like if you do it and it doesn't work, you take it away. You haven't changed anything. Like surgery is irreversible. Doing braces and stuff is irreversible. So there's no real good studies of like getting your teeth perfectly lined prevents it. A lot of my people I see they've finished braces because a lot of them are teenagers. There's sort of like a couple of age peaks that get it. So I see people like that. Majority of people don't need surgery. Most of them it's splint, the mouth guard, splint therapy, buying time, anti-inflammatory, stress reduction, exercise, all kinds of things like that. And the very few people that may need some sort of surgery itself is, and I send them to the University of Iowa, and they won't even see you there really until you've exhausted these conservative approaches, And then sleep apnea, I'm always assessing airways because for doing sedations and things, we're always looking at airways and looking at the anesthetic risks and things like that. So I'm always trying to kind of identify folks that may be at risk for sleep apnea and try to get them over to the sleep center. With that, surgery-wise, from an oral surgery standpoint, the people that don't tolerate CPAP or don't want it, I think the big treatment for that is really what's called, maxillary mandibular advancement, is actually moving the upper lower jaw forward. That's really the only surgery that it's proven to be beneficial for people with really bad shift to sleep apnea. But there's not a lot of guys that do that. I got to send you to a tertiary care center for that because they're usually higher risk people for the surgery. But
sure.
But CPAP, that's most people are treated with CPAP, as you know, and if they There's oral appliances that can be tried for milder versions that may not need CPAP, and they're always, they need to be adjusted and things. And frankly, I'm so busy, I don't really have time to be making those things.
Sure.
So I defer them to the general dentist, because they see it frequently. They
Yeah.
can check them out, adjust them. If they have a new crown put on the tooth, they can modify the appliance, like an oral appliance. So,
Sure.
so I'm kind of looking at people and then trying to guide them in the right direction. But as far as like defects, cleft lip and palates and things, when I was in residency, we did that because where I trained, we had a cleft lip and palate and cranial facial surgery team, and we did the the lips and the palates and things there. But you got to be here in our area, you got to be in Chicago or up in Rockford. But they got to. But down in Champaign-Urbana, where I was, there's at Carl Clinic and Hospital, there's a cleft lip and palate and cranial facial team there. So you got to have everybody working together really for that. And so that kind of went off the menu of procedures to be done.
Sure. Sounds good. So, Dr. Whitaker, I'm going to be letting you go here and let you go get on one of your bikes.
Yeah. I've been doing. I need to do it more often. But
Dr. Whitaker and I are both bikers.
Yeah.
The one where you pedal, bikers, I should say.
No. My wife won't let me have the other one. so the day she lets me have one, I'll have to wonder,
What's she trying to say, right?
Yeah, I know. That's right. Yeah. But no, it's been fun. And sorry about the glitches there earlier. I don't see any loose cords that I hit or anything.
All right. It's all good.
It's fun. So
it's all good. Well, Dr. Whitaker, thank you so much. Been a good time. And thank you for your many years of service here to the community in Sterling, Rock Falls and surrounding areas. You are the real deal and good guy. And we're so glad to have you.
Hey, well, thanks. I appreciate it, Bill.
All right, everybody. Thank you. And we'll see you next week. Take care.